and welcome to today's webinar. I'm Allison Hughes, and I'm a board member of the Arizona Rural Health Association. Want to welcome all of you. I'd like to extend a special welcome to all who have joined today's webinar, especially those from the Rural Health Associations and from our Southwest region. Thanks are also extended to our statewide co-sponsors, the Arizona Telemedicine Program, the Southwest Telehealth Resource Center, and the Center for Rural Health located at the University of Arizona. We respectfully acknowledge the University of Arizona is on the land and territories of Indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the Tohono O'odham Nation and the Pasquayaqui tribe. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign Native nations and Indigenous communities throughout education offerings, partnerships, and community service. Since 2011, the Southwest Telehealth Resource Center has partnered with the Arizona Telemedicine Program to bring you over 185 informative webinars. And Chris Stewart is with us today in case we have any technical difficulties. So thank you for that, Chris. As you joined the webinar today, your microphone was muted. Please use the chat function of Zoom to ask questions. Questions will be answered at the end of the presentation. Today's webinar is being recorded, and you'll be able to access on demand from our website at telemedicine.arizona.edu/webinars/previous. The URL is listed on this slide, and we'll also post the URL in the chart. Onward, Alan Morgan serves as Chief Executive Officer for the National Rural Health Association. Recognized as among the top 100 most influential people in healthcare by Modern Healthcare magazine, Alan Morgan serves as Chief Executive Officer for the National Rural Health Association. He has more than 26 years of experience in health policy development at state and federal levels, and is one of the nation's leading experts on rural health policy. Mr. Morgan served as a co-author for the publication Policy and Politics in Nursing and Healthcare, and for the publication Rural Populations and Health. In addition, his health policy articles have been published in the American Journal of Clinical Medicine, the Journal of Rural Health, the Journal of Cardiovascular Management, the Journal of Pacing and Clinical Electrophysiology, Cardio Electrophysiology Review, and in Laboratory Medicine. Good work, Alan. Mr. Morgan also served as staff of former Congressman Dick Nichols and former Kansas Governor Mike Hayden. In addition, his past experience includes tenures as a healthcare lobbyist for the American Society of Clinical Pathologists, the Heart Rhythm Society, and for VHA Inc. Alan has a bachelor's degree in journalism from the University of Kansas and a master's degree in public administration from George Mason University. Today's mid-year rural health policy roundup is the 9th consecutive year Alan has briefed us on important policy issues impacting rural Americans. Thank you for your work, Alan. You're wonderful, and take her away.
Thank you so much, Allison. And for those of you that may not know of Allison's work, I believe Allison has won every national award that our organization can provide to anyone for her leadership on rural health and addressing underserved populations in her career. So it's always an honor to be with you here, Allison. 9 years, so that explains why I have this picture here without any gray hair. And you notice that in my live view, I've accumulated some of those gray hairs over these years. So I'm going to keep using that picture as long as I possibly can. Hey, I hope you all are aware of the National Rural Health Association. If you care about rural health, rural policy in rural communities, there's a home for you within our organization. We like to say we're your voice louder because we work together to tell an authentic story of what's happening in rural health and rural America. And that's what I'm going to be hopefully doing for this fastest hour in health policy that you'll attend all this month. What I want to try to do from a standpoint of presentation is start off with a consistent view of how we tell this story. If you're on this call, you know rural health, but I think it's always helpful for us to be talking about it in the same way. And that's what I hope to do in this first part of the presentation. And after we cover what makes rural unique, then we're going to talk about COVID. You can't have a policy discussion these days about covering the impact of COVID-19 on rural communities. And then, of course, I'll finish off with the fun stuff, and that's what's happening right now in a policy perspective at the federal government and nationwide that's going to impact your work, not just today, but into the coming years. So let's start with this slide, which is perhaps my favorite slide of all times, because it shows a father and a daughter looking out into a beautiful sunrise. And I gotta be honest with you, that's honestly how I like to view rural America, as sort of a episode of any of your favorite Hallmark shows that you might watch. And this father and daughter, they're looking off into this beautiful sunrise and they see workforce shortages, vulnerable populations, and chronic poverty. Yeah, that's the challenge that everyone on this call faces when we talk about our lives in rural America. It's telling that authentic story. And in the media, they only get half the story right. They're either rural America is a Shangri-La, which you all need to move to right away, or it is a hellhole where people are dying early or plotting to overthrow the US government. But the fact of the matter is, rural America lies in between, right? You know this. Yes, we have tremendous challenges, but in those challenges are innovation. And rural America is where innovation happens when it comes to rural health. So it's important to be telling an authentic story about the assets and the challenges that we face in a rural context. Hopefully, you can identify your dot on this map. Currently, roughly 90% of the nation's rural hospitals, rural health clinics, and rural community health centers are members of the National Rural Health Association, and we do have strong representation from the state of Arizona. I have a lot of discussions with people here in Washington, D.C., and they want to know, why don't you have the members out in Western U.S. that you would expect? Well, you know why, because 90% of those lands where we don't have members are federally owned lands, and people don't live there. But the important thing is, I think we all, from time to time, should refer to ourselves as the National Small Town Association, because that's really more accurate of where our members live, work, and reside. We do have members who are farmers and ranchers, but for the most part, our membership resides in hundreds of small towns all across the United States. What we do as an organization is exactly what we're doing here today, and that is identify best practices, share those best practices for replication across the United States. And I am absolutely thrilled to see that we're going to be going back in person finally next year. I've enjoyed these last couple of years at home, but like you, I'm ready to get back out to the conferences and see people face to face again. So I hope you mark on your calendar February 8th through 10th, where we'll be back in person here in our nation's capital, meeting with our policy leaders for our annual Policy Institute. All right, for those of you that can remember my presentation last year, yeah, I'm using the exact same slide that I used last year. I just changed 2020 to 2021. I think it's relevant because at some point we have to stop calling every year an unprecedented year when it comes to rural health policy. Again, we're in the midst of a global pandemic dealing with workforce shortages, hospital closures, and at a time when we have great upheaval in our nation's capital. So yes, it is an unprecedented time, but when it comes to rural health policy, it's beginning to feel like Groundhog Day. So let's kick this session off then, just getting a shared understanding of rural health and what we're seeing within our rural communities. And I mentioned earlier that, yes, we face significant challenges, vulnerable populations, systemic workforce shortages that have persisted way before COVID-19, limited resources for provider, and lack of funding. What I like to tell policymakers is, yes, rural America has a lot of challenges, but if you really want to see where the United States is going to be at 20 years from now, look towards small towns now, because with the changing demographics of our population, increased pressures on providers, and lack of adequate reimbursement, increasing health disparities, where rural America is today is really where our country is going to be in the future. So that's part and parcel the importance of figuring out how to deliver high quality healthcare services in rural America now, so that way we're prepared to deal with these issues later on. Okay, so I find this very useful when I'm talking with local authorities, state and federal authorities. Just the easy reference that rural America is older, sicker, poorer. What that means is rural is not a small version of urban. Rural health is a unique healthcare delivery environment. Solutions that work in an urban context not always, and in fact seldom times, can work in a rural context. That is so very important. The population is older, more health disparities among the population in these communities, and a lower income among those communities. Now, let me take a pause here. And what I'm sharing with you is the messaging on this. But if you're on the call right now, there's a fairly good chance that you know rural fairly well. And so let's acknowledge that it's more complicated than that, right? In fact, when you're talking about frontier America, it's difficult for the federal government to actually designate medically underserved populations when it comes to frontier America, because if you're living in remote Arizona, chances are very good that you have really high health standards and you're one of the more healthy individuals in the United States. You have to be to live there. But because of that necessity to really be in great shape in frontier America, it distorts those most rural, remote areas. So that's just an acknowledgement that rural health is complex and complicated. But when conveying this to policy leaders, it's just of paramount importance that we convey this in a consistent, easy to digest manner, so that policymakers actually understand that they can take action on these issues. Now, to further highlight that, I like this map because if you recall our map earlier where NRHA members were at, you see that map correlates exactly, unfortunately, where Medicare patients with 6 or more chronic conditions are located at. And it certainly is the case there in Arizona as well too, and nationally. Rural America, again, is that population where those most in need of healthcare services oftentimes have the fewest options available. And that I mean by workforce shortages. Okay, well, you're not going to have a presentation from me without talking about the hospital closure crisis. The challenge for me is, how do I make this relevant and important to you regardless of where you live, and certainly in Arizona? Arizona's been facing struggles with its rural hospitals, but not as much as other states. So let me make sure that I convey why this particular issue is of direct importance to you, regardless of whether you work in a hospital or clinic setting. And it's this: when I talk with policy leaders in Washington, D.C., and we talk about hospital closures, they often shrug their shoulders and say, well, it's because of volume and people are leaving rural America, so what are you going to do? It's the volume that's causing these closures. That's not the case. Just look at this map, for example. If volume was the primary driver, then it would stand to reason that the bulk of hospital closures would be happening in North Dakota, where you don't see any, South Dakota, western part of it, Nebraska, Kansas, Oklahoma, really that beltway of the United States, where we actually are seeing decreasing populations among rural communities. But that's not the case. It's not the case. This particular slide is a look back, and it shows that the bulk of the rural hospital closures to date have happened in the Southeast, not in that slither of the US where rural populations are actually decreasing. Now, if you look at where we're seeing going forward, where are the hospitals that are vulnerable? 453, you see these fingers starting to move out from the Southeast into the mountain states and upper Midwest and into the Northeast. The issue here is not the volume, it's the population. And the fact of the matter, what I've shared with you earlier is so relevant here. What we've done is we've clustered within these small towns people with high health needs, with in many cases are underinsured or have a lack of health insurance. This is an equity issue. This is an equity issue. And in fact, according to the University of North Carolina, more than half the rural hospital closures that have happened to date have happened in communities with a higher than average Latino, African American, and a rural Hispanic Latino population. So it really is an issue of these hospitals operating in communities without adequate insurance. And I think you see that in this particular map. Again, what I'm doing here in this presentation, this is a policy update. So I'm conveying to you a policy slice at this to try to make sure that when you're talking with policymakers, we're talking about equity within these rural communities. All right, again, let's talk about the complexity of rural America, shall we? I think when you look at the health disparity, you definitely can see the population is driving a lot of this, both from a reimbursement and uninsured perspective and a health perspective, but let's be honest, it is much more complex than that. It is both, it is not both, it is all health disparities, population migration in some issues, the problems of recruitment and retention, economic policies, healthcare policies, and yes, now COVID-19 on top of that. It is a complex set of issues that are impacting access to care among our rural communities today. And now COVID-19 is coming to bear the weight on this issue. So with that, hopefully, very, very brief overview of the many challenges that we face and the opportunities we face when it comes to rural health. So let's grab the bull by the horns and talk about the impact of COVID-19 on rural communities. Before we do, I just want to tee up two key takeaways here on this particular topic. Number one, and this is important, rural perception drives healthcare policy, whether it's rural or urban. Public perception drives healthcare policy. If you want to drive policy, you need to make sure you're working with media to share the authentic story, going back to the very opening of my presentation. That's number one. Number two, let's also acknowledge perhaps the quickest way to get yourself fired from any job is to talk to the media, right? It's one of those necessary evils. And why I'm sharing this with you at this point is while I've become a talking head over the last 2 years, you working in rural health are the ones who should be talking to the media to tell this story of what you're seeing in your communities. It is so very important, number one. And number two, I just want to highlight this. You note that both on here, I've spoken to Fox News and MSNBC and One America and Al Jazeera TV because I am approaching this from a rural health standpoint, not a political standpoint. I've stayed away from the politics, and I just want to say what is actually the experience of rural communities and rural providers in dealing with COVID-19. I would encourage you all to do that as well, keeping the politics out of the healthcare when it comes to rural communities. All right, that being said, what has been the experience? And I'll be honest, sometimes I feel like this is the only slide that I need to really show in my presentations. You are more than twice as likely to die from COVID if you live in a rural town. That's just outrageous. And if that's not bad enough, to date, the experience that we've seen is that in rural towns across the US, COVID-19 is happening at an 80% higher rate than in urban areas. So 80% more likely to get COVID And then you're more than twice as likely to die from it just because you live in a rural community. That is just outrageous. And I think that really tells the key story as we move forward. To date, COVID has been viewed as a national problem. Moving forward, we really need to start realizing that this is going to be a uniquely rural issue moving forward. And just as in the beginning of this pandemic, how we treated assisted living and nursing homes as areas and facilities and populations at unique risk for COVID, and we took appropriate measures, it's past time that we recognize that rural America is at particular risk for COVID moving forward. And as such, we need to act accordingly on that. Unfortunately, to date, that hasn't happened. And I know you've all heard the stories right now. Currently, rural America is vaccinated at less than 10% or 10% lower than urban areas. And I realize that even among our family and friends, they have different views on vaccines, but when you just look at the vaccination rate, the incident rate, and the mortality rate, just looking at the data, you recognize we're doing something wrong here. And with the mortality that we're seeing and the impact on our providers, we need to take some different approach on this. Now, let's tackle a very complicated and very politically charged issue, and that's of vaccine mandates. And I'm putting the slide up here right now just to highlight the federal funding to date on this and to share. Hopefully, your providers over the last couple of months have already applied for the forthcoming next iteration of federal assistance, which can be used for hiring traveling nurses and staff at a higher rate, just to make sure that you have adequate workforce going ahead. And that's really an issue. On one hand, you can say because of the severe workforce shortages that rural faces, we really need our entire workforce vaccinated. You can say that. And because healthcare workers are community assets, we need to treat them as community assets and make sure that everyone's vaccinated. Knowing that, it's not counter to also say vaccine mandates are going to lead to health service disruptions in a rural context. That is going to happen. At the National Rural Health Association, the important thing is understanding that vaccine mandates, if they move forward, are going to lead to service disruptions. It's appropriate now for the federal government to articulate what is the plan to assist these facilities when that happens. And we've been talking with the administration exactly about that. What is the plan? Now, the federal government has a lot of tools at its disposal, and so do the states. It's our expectation, as I mentioned with this particular slide, the federal government will distribute in a timely manner in the next couple of weeks the next trunket of funding to be able to allow these providers to hire additional staff in case they lose staff because of the vaccine mandate. In addition to that, we need to be looking at deployment of public health service professionals, deployment of FEMA. We need to make sure that within the Health Resources and Services Administration, the workforce programs are fully utilized as well. At the state level, we need to make sure that the National Guard is positioned to deploy to communities that may be at risk for closing their doors because of losing healthcare professionals, because they don't want to get vaccinated. And also, we need to make sure that the local medical schools and nursing schools are prepared to send their students in as needed and as appropriate to make sure that we don't see health disruptions. So you're hearing a tremendous amount about that discussion now. And again, I want to say it's not an either or. We have to get everyone vaccinated among our healthcare workers. And two, we have to understand there will be impacts of this as we move forward. At the end of the day, regardless of whether it's mandated or not, let's acknowledge this is a personal choice. And I really firmly believe that we've been communicating this incorrectly to date. From a rural standpoint, and I'm from a small town in Kansas, we don't like to hear the federal government tell us what to do, let's be honest. And that should never have been the messaging. So we partner with the U.S. Ag Council, with HHS, with CDC, and with other entities, including the Rockefeller Foundation, to develop rural relevant messaging on this. And if you forget everything else I say today, just remember the words rural health. Google, Yahoo, Bing, rural health. Our website is always one of the top 3 things that pops up. And on there, we have provided free tools and resources that you can customize for your own community on how to talk about this, how to talk about what we need to do from a civic pride standpoint to keep our businesses open, our kids in school, and our fragile workforce safe and on the job. And as we move forward, as I said, from the data on this, this is not going to get better. It's going to get worse as we get into the winter months. And it's actually impacting life expectancy of rural communities and rural populations. Again, I'm going to finish up this segment on COVID just by providing these particular resources and by sharing the fact, and that is our populations are most at risk for COVID. Our healthcare systems in rural communities were never designed for a global pandemic. They were designed for primary care, general surgery. And so in these communities, most at risk, with the fewest resources available, it becomes incumbent that we are at least utilizing all public health measures that we can to keep our communities safe as we move forward. Okay, so with that, let me get on to the fascinating world of what's happening in Washington, D.C. and its impact on all of you at this point. And Allison, it might be helpful at this point if you can mute your line. I'm getting a little bit of feedback from you. All right, so talking about this, this particular slide, I'm glad that I'm providing these slides to you in advance take home, because this is my cheat sheet. I have a hard time keeping track of all the various funding measures that have come out from the administration. And this actually lines them up. So you can see over the last 2 years, the various funding and public health, both proclamations and federal actions that have impacted rural America, not including the one that the president is signing today. So as we speak, president is signing the infrastructure package. And it's been a little bit confusing, I think, to the general public about what exactly is in this package. You know, a particular interest to not just rural health, but to the people on this call is the $65 billion commitment to broadband connectivity, which is the largest commitment that we've seen to date on this. And it is imperative that we have broadband connection for our healthcare going ahead. So really, from my perspective, that's the alpha and the omega of this package. Now, I asked our team to pull together what are the other rural specific provisions in there, and you see these outlisted in here. And you certainly can make the case that clean water is important from a rural perspective. Cleaning up these Superfund sites that occur predominantly in rural America is also incredibly important. But again, I go back to the very important, the significant importance of broadband expansion. So as we move into this, the next obvious question is, what the heck is in this? I'm gonna go ahead to the Build Back Better framework, BBB, as you hear, and this is being discussed in Congress right now. And just to use a rural analogy, this is going to be the last legislative vehicle that passes this year. And so think of this as a pickup truck. And from a rural perspective, we're trying to throw as much stuff in the bed of this pickup truck as we can before it either gets across the finish line, hopefully, or crashes before it gets there. And at this point, it's not clear what is going to happen. What we're pushing for within this package in particular is additional funding for rural workforce, which is really concern number one right now when it comes to our healthcare infrastructure. We're pushing for additional rural maternal health support. We're optimistic that we'll get some modernization of the rural health clinic program included within this as well too, and telehealth. And yeah, okay, so before I get into the telehealth component and why this is such a particular important issue for all of us, let me back up and say this. I think we already know what's going to happen in the appropriation process. Nothing's official until it's official, but it's about as close to being official as you could hope for on this. It is highly likely that when the current funding time runs out in December 3rd, we're going to see what's called a continuing resolution going through into the next year. Continuing resolution just basically means Congress couldn't agree on it, so they're going to lock in the current level of funding moving forward. I'm happy with that. I think from a rural advocate standpoint, if you are receiving telehealth grants from the Office of Telehealth Advancement, or if you're receiving small rural hospital improvement grants, funding from the Federal Office of Rural Health Policy, basically any funding that impacts rural programs or grants, you're going to see level funding going ahead. And I'm always excited about that. I certainly would like to see more investment in rural health, but at least we're not seeing decreases in investment. And important for you, if you're receiving grants at this point, to know, okay, this funding is stable going into 2022. So that's sometimes good news is no news, and that's where we're at. And it also highlights what I mentioned earlier. Since they're likely to do a continuing resolution on that, again, really the last legislative vehicle we're going to see go through Congress before 2022 is going to be the potential for this Build Back Better investment plan. All right, so if that is the last potential, I can't stress to you at this point how important it is for continuing the telehealth flexibilities that we've seen to date and expanding upon those. Let's talk about telehealth. All right, you know, I hope like you've heard a multitude of amazing stories about telehealth utilization in a rural context during this COVID crisis. You know, whether it's the rural hospital in North Carolina that utilize telehealth to expand ICU capacity, or whether it's the rural dentist in Virginia that incorporated teledentistry and built in primary care into his teledentistry practice, so he was able to refer patients when needed onto the local hospital, or whether it's upper Midwest and the significant expansion from primary care into the homes of rural America. We've all heard of these. And so I think it's the general assumption that rural telehealth has flourished during this time. So that's the reason why I'm really concerned about looking at the actual data. What does the actual data show? And from the experience, I think even from where you're at, you can recall back during the very beginning of this pandemic and the significant uptake of telehealth at the beginning of this from a rural perspective. Not as much as urban, but there was that significant uptake. What I find shocking is looking at the current data about utilization since that time. And the great stories I hear are not matching up with the national data. And this particular chart doesn't show it as well as this chart. I mean, what has actually happened is we've seen a great uptake among urban telehealth that actually continues to increase since that time. But while at the same time, rural telehealth just has not taken off. It has not taken off. And I think that's a particular concern for all of us because of any geographic area that has the most to gain from whether it's telebehavioral health, teleconsultations, tele-ICU, or what we all really hope is the final move forward towards primary care from a rural health clinic or rural community health center into the patient's home. And we're just not seeing that adoption occurring. And at this point, I don't know that we have the answers for it. Everyone has their own theories on this, and they range from, well, it's because the clinicians haven't adopted in a rural context. I need to see the data on that, because I think we all know of cases of rural clinicians, and rural clinicians generally are an older population than other clinicians, and rural clinicians on the front end seem to be on the forefront adopting telehealth to keep them safe during the beginning of this COVID pandemic. And that's not quite reflected in this data. Is it reimbursement? Yeah, I still think there's some reimbursement components of this when it happens to, in context of some rural health clinics getting out there. But that being said, the recent physician fee schedule will continue to permit telephone usage within a rural health clinic to the patient without video, just using the telephone. So I think there's certainly measures in place to try to help make this work in a rural context. Is it broadband? Sure. I think broadband has an impact on this to a certain extent. The best guess in talking with policy leaders at the national level and researchers at this point is that what we're seeing is urban providers are doing a much better job of pushing this option forward onto their patients than rural practitioners are. And what we're seeing in the larger health systems and larger urban providers is in communications out with their patients, they make the telehealth option prevalent and easy to use. Whereas this is perhaps not occurring as readily in a rural context. But again, I had to be careful because there just isn't the data out there to show what is driving this lack of uptake in a rural context. And the reason why I'm spending so much time on this twofold: one, because it's important for this particular community to be focused in on who are on the call right now, to be focused on this. But this is really man bites dog data, is it not? I mean, it's just, again, all the stories we've seen in the media, what we've heard from our membership, we just assume that telehealth, rural telehealth is flourishing. And unfortunately, the data doesn't show it there. The importance behind this is there is no path forward for rural health that doesn't incorporate telehealth. Whether we're talking about new payment models or new provider types, both of which are a key provision of these are telehealth. Any of the global payment models that were currently being tried in Pennsylvania, or the soon to be released rural emergency hospital designation program, they all rely on a strong presence of telehealth. We have to have that in the mix going ahead. So I think it's important for all of us to recognize this, and I'm very much looking forward to seeing additional research in the near future to try to figure out what are the barriers to adoption for our communities on this. All right, I've covered a lot of stuff, but as usual, only touch the top line of it. I do want to say that I'm encouraged both this year in legislation and national and practice to see the recognition and expansion of rural residency training programs. Over the last couple of years, finally, it feels like we're turning the corner on realizing that, you know, identifying kids that score high on their MCATs who are from upper income urban communities and training them in urban areas, and then being dumbfounded that they don't want to practice in rural America is perhaps not a good way to be dealing with workforce in the United States. And both from the funding perspective and the actual practice application, we're seeing more and more schools and nursing schools focus in on how do we attract and retain rural students, train them in critical access hospitals and rural community health centers, and then place them in those communities where they want to live. I want to hit on behavioral health. A few aspects of telehealth have more promise in rural than rural behavioral health, certainly with the lack of behavioral health specialists in a rural setting. I'm expecting that in the next Congress, we'll see a renewed focus on this, certainly coming out of this pandemic. And then I want to make sure I touch again on the efforts to modernize the rural health clinic program going ahead, making sure that provider-based rural health clinics, those that are not freestanding rural health clinics, but those that are affiliated with a rural hospital, are paid at the appropriate level, and also are permitted to create new rural health clinic sites as we move forward. And just so you know, there's a lot of focus on this right now in Congress, and there's a focus on having this happen, and at the same time ensuring that there are quality measures and reporting requirements into this. This is a little bit of a difficult issue because rural health clinics by their various nature are low staffed and struggling just to keep up with administrative burdens, and it seems counterintuitive to now place quality reporting measures on these small struggling rural health clinics. But the fact of the matter is, it's just, we've seen over the last 20 years, rural community health centers have been able to have a wealth of data because of their quality reporting efforts. Rural health clinics have not. And it puts rural health clinics just at a disadvantage when it comes to both inclusion in new payment models and also regulatory proposals that actually adequately address their needs going ahead. More data is better when it comes to policy. Okay, so bringing this whole program to bear here, again, I just want to leave with a resource and a tool for everyone on this call. Google Rural Health, or Yahoo Rural Health, or Bing Rural Health. Once you get on our website, this year we've launched a new legislative tracker, and we've made it as easy as possible for you to see every piece of legislation that's currently in Congress that has a rural health perspective on it. And I hope you're able to utilize this free tool, regardless of whether or not you're an NRHA member, to advocate on behalf of your community. And at this point, we really are focusing in on the impact of COVID on rural providers, asking Congress to protect those providers, and making this pivot, making a pivot away from dealing with COVID to pivoting into how do we build a sustainable healthcare system for the future. And that really is talking about the investment in telehealth and systems of care as a result of that. Well, let me say that is, again, has been the fastest 40 minutes possible in healthcare. I see I'm right on schedule because I like to give 20 minutes. So if we have Q&A from the audience, we can hit that, because as you know, there are unlimited issues when it comes to telehealth that we deal with. So at this moment, I'm going to turn it over to Allison to help me field the questions from the audience.
All right, thank you, Ellen. That was, as always, 9 years in a row, fantastic. And we have a lot of questions that are coming up in the chat, so let's get going here. Let's see, Peter Kaplan, he was the first one to write a question for you in the chat. He's wondering about the number of clinicians, that is physicians and nurses, who are taking advantage of tuition write-offs for rural service, and the numbers, percents of providers actually going into rural practice. What do you know about that?
Well, I do. Thank you for highlighting that. I really appreciate it. At the beginning of this year, in January, February, there was an additional, now off the top of my head, I can't remember whether it was $800 or $900 million provided for the National Health Service Corps. And I apologize, $1 million here and $1 million there, it adds up after a while. But a significant increase in the funding for the National Health Service Corps. Why is that important? Because National Health Service Corps, you have to have is allocated by a scoring mechanism. And oftentimes, sometimes rural is not actually benefited from the scoring mechanism because there's limited funding, and many inner city urban areas just score higher than rural places do. So I'm really encouraged by that additional funding level. But I go back to what you posed that question at the beginning of the presentation. Now let me talk at what I mentioned at the ending of my presentation on that. It is a fact. It is a fact of the matter that the vast majority of clinicians going into rural America are from urban areas. That is because, as the Health Affairs study that was published in 2020 indicated, the amount of rural kids going into medical schools is at an all-time low. And so it's important on one hand to make sure that we continue pitching rural to urban kids because that's the majority of them, but that is not the proper way. We have to do a better job of growing our own. And when you are working in an AHEC or a community health center or a hospital or clinic, we have to be pitching to our local students, there's a job for you. And some state loan forgiveness programs coupled with the National Health Service Corps, hopefully, and in sometimes partnerships with the local providers themselves, keeping our kids in our communities. So the actual numbers, I have not seen it from this year, but that's a good question. I'll be checking on that after this call.
Thank you. Jack Beveridge is talking about schools, adding schools as stakeholders, rural schools providing healthcare access to the students. Can you address that?
Yeah, that's the best way out there. And in fact, we've been talking with the National Council of State Legislators about successful models for that in particular. If I'm talking on rural health and I'm not raising schools, transportation, and housing, those three components, I'm in the wrong meeting. And the partnership between local schools and then also equally, whether it's the community colleges or the nursing school or the medical schools, making sure that that linkage is provided. And I will say we had a meeting with senior staff of HRSA, was that a week and a half ago on this particular issue. And I'm hopeful that we'll be pushing out to our membership in the next week and a half additional tools and resources from HRSA on this.
Thank you. Moving on to telehealth and what you were talking about here. A couple of comments here. Mary Ducharme, Montana says their telenet home health is permitted, not reimbursable. Kate Cross writes that pediatricians had a surge in telehealth and have drawn back. Many are urban, but she says what she hears that she wonders if it has to do with the lighting being consistent with skin color, et cetera, et cetera. There's some challenges, and actually the quality of the lighting, et cetera, when you see the patients. Yeah.
Well, that's good to hear. Hey, and I would say this also for if you're on this call, and my email is listed right here, do not, please do not, if you've got a couple minutes available, please just drop me a quick email on your thoughts on some of these barriers on telehealth. And again, without the research, it's really tough to know. And I'm really interested in hearing any specific examples that you're seeing on what are the barriers right now to telehealth. And the quality, that's a broadband issue. And it's a equipment issue as well too. I will say this: I've been with NRHA for 20 years actually, and one of the great things is I've gotten out to see a lot of rural communities, which is the highlight of my job. And I have seen particular sites both in North Dakota and Tennessee where there was cancer screenings. And in both cases, the clinicians said that they actually liked remote cancer screenings better than in person because of the technology. They were able to zoom in and get a higher definition than if they were there in person, which to me is just amazing. I think it's an example of, there are certain cases where I think we need to think of telemedicine not as a poor substitution, but if the broadband is there and the technology is right, you can actually have better care, hopefully, by bringing in some of the state's top specialists into these rural communities as a result of that. And that's a good jarring thing also. One thing I forgot to mention is nationwide, and I don't know if it's been reported on as widely as it should, nationwide in rural hospitals, they are seeing volume levels like never before. And the recent research out of University of Minnesota indicates that because we saw a lack of screenings during the first part of COVID, that now is really creating additional burdens on rural hospitals and clinicians now at this point. And it goes to the heart of the matter of screenings and preventative medicine, addressing health on the front end. And we've seen that as being a challenge for rural health in the past. It's exacerbated under the current situation.
Thank you, Alan. Someone wrote in earlier about oral health, dental health, and the rurals. It's been a long time issue. Could you address that?
Yeah, I think, at NRHA, we cover a lot of ground, Allison, and oral health is the one issue that regardless of whether you're in a hospital or clinic or a community leader, it unites everyone because in a rural context, oral health impacts the economic health of the community. Without good teeth, having that good job in the community makes it much more problematic. And the data shows how oral health is central to the health of overall health, but yet we pull oral health out separate than everything else, whether it's quality reporting or reimbursement through the Medicare Medicaid program, and we see the consequences on it. And I will say, again, we've seen a movement towards integrating primary care into oral health, which allows in a fragile work environment to be able to expand healthcare and hopefully send patients to the local hospitals and clinicians as necessary. There are ongoing discussions of including within Build Back Better, expanding oral health within the Medicare Medicaid program. It's unfortunate, but it appears that might fall out. Everything's up in the air right now. But I think going ahead, trying to include an oral health benefit, in particular within the Medicare program, and expanding teledentistry, which sounded so far-fetched 2 years ago, but now there's just been so many examples of how that screening process is just so beneficial for rural patients. I think those are the two big issues that we'll see. The one thing I'm interested in is how oral health is going to be integrated into these new payment models like global budgeting. That may be the best case forward for providing the funding necessary to see expansion of oral health care in rural settings.
Thank you. We're moving along at a good pace here, Alan. We have time for 2 or 3 more questions. And I see a question here from Kevin Driesen asking if you have any thoughts about comparative prices on rural hospice care.
Wow, gosh, that's a broad question. That's a broad question. The concept of hospice in rural America is one that's both intriguing and questionable. I don't know if it's been, I should have mentioned it earlier, but over the last decade, according to the University of Iowa, we've seen a 10% decrease in rural nursing homes. 10% fewer rural nursing homes. Now, the unusual aspect of that is when you look about hospital closures and clinic closures, and you look about health disparities, you look at COVID itself, the Southeast US is just a red spot of closures and health disparities, except for nursing home care. Nursing homes have stayed stable in the Southeast, where the 10% have closed in upper Midwest, the mountain states, and out west. To me, that's a policy outlier. Why is that? I think why that is, this is, again, research is being done on it, but it would seem to reason whether it's hospice and assisted living, these are issues that more affluent rural Americans are able to afford and engage in. And the concept of utilizing just nursing homes for end-of-life care is something that Medicaid covers. And so it's we've seen that stayed stable in the Southeast. But I think as we move forward, the concept of both living at home, aging at home, assisted living, and the very important issue of hospice care, end-of-life care as well too. It's been an understudied, undervalued aspect of rural health, which I'm hopeful we'll see more focus in on, but to date it hasn't been. I hope that's a long-winded answer for that.
Well, thank you. Elisa Rosier writes that she's the only pediatrician on the fourth largest island in America, rural Alaska. She says she's ineligible for many rural telehealth funding opportunities because she has an LLC and not a nonprofit. Is there anything that could be done about this?
Oh my gosh, thank you for bringing that up. That has been a particular sore spot with the National Rural Health Association for 15 years. Ownership status should not preclude you from grant opportunities. That's ridiculous. And trying to get that overturned, we are working closely with the Federation of American Hospitals, the national organization of the for-profit hospitals, to try to open that up. And I get it. I understand on the surface of it. People say, oh, if you're in for-profit, that you shouldn't be getting this access to the grants. But the fact of the matter is, in your particular case, or the nation's rural health clinics, you're seeing a vast majority of these points of access when it comes to primary care being small for-profit entities that unfortunately still need that access because they're dealing with an underserved population. From a policy perspective, NRHA has been consistently stating that ownership status should not preclude you from accessing grant availability options when you are in a underserved population and underserved area serving an underserved population.
Thank you again. And we have about 3 minutes left, Alan, before we conclude this wonderful webinar. And we have a question here from Dan Dirksen of Arizona, asking if you're interested in commenting on enhanced FMAP to expand direct care workforce, home, community-based services, including family members. Quick answer to that one.
Oh gosh, Dan, thank you for ending with the toughest question that I received today, and good to hear from you. I'm glad you're doing well. Yeah, we're supporting it, but I haven't heard any movement on it.
Thank you very much. Well, with that, we should conclude this webinar today. Alan, once again, thank you for everything. We'll see you again on our decade celebration next year. We'll make it a good one. Everyone, thank you for participating. It's been very productive session. And if you have any further questions, please email Alan directly. You'll get a fast answer from him. I can guarantee you on that. And I assume your email is in the chat, Alan, yeah?
Yes, and it's actually on the screen right now. If you missed that, see the one on the screen. So I'd love to hear from all of you. Thank you so much.
Thank you once again, and thank you, Telemedicine Southwest Research Center, for making this possible. Goodbye, everyone.